And we have been actually doing it for the past 2 years or so, because in Kerala, the situation when compared to the rest of India is a bit different because of our, the blunting the peak and plateauing strategy. We were never out of cases in Kerala. So all of us now are, I believe that all of us are aware of all the guidelines, no need for any refresher training or anything. But then, we are on the verge of an Omicron outbreak in Kerala as well. So here the strategies need to be a bit more different, because the behavior of Omicron when compared with Delta or the previous Alpha or the D614G or the original Wuhan HU1 strain, etc., are a bit different. So Omicron behaves a bit differently. So if the virulence is not very high, but there is a possibility that our healthcare systems might get flooded with patients. So the onus is not on the optimization of the treatment strategies, rather on how to plan. If there is a surge is occurring, then our focus has to be definitely on home-based treatment. And that is in this context that we plan to have a refresher training session focusing just on the home-based treatment plan. As you all know, on 5th January, the Union government, Ministry of Health and Family Welfare, did come out with an updated home care guidelines for the nation as well. So I will be taking you through those guidelines as well. So I would like to thank NHM for this opportunity. And then straight away start with the presentation. So the presentation will have two parts. One is with regard to the COVID-19 home care guidelines, which we are very, very familiar with. And second session will be on the empowered home care guidelines, which we actually did release during the peak of Delta wave. That was one situation where the ICUs were getting filled up. So there was a situation where we need to take care of even the category B2, that is those with comorbidities at home. We'll brush through the empowered home care guidelines as well. So we will begin with the home care guidelines. So background is, over the past 2 years, it has been seen globally as well as in India that majority of the cases of COVID-19 are either asymptomatic or have very mild symptoms. So we know that even during the Delta wave, around 60 to 70% of the patients were really asymptomatic, or they did have only mild symptoms. We'll take the case of the Kerala data. During the Delta wave, around 5% of the patients developed severe infection, severe COVID-19, of which around 1.5% required ICU care and around 0.5% required NIV or the ventilation like that. That was the stats. So for every 100 patients, around 5 patients did really become sick in case of the Delta virus infection. So the international figures was around 15%, but the state-specific data is around 5%. So definitely became sick. When it comes to Omicron, we look at the data from Denmark. So the hospitalization is only around 1%. They will in Europe, etc., they will admit only those patients who are hypoxemic. So they will admit only the hospitalization was required only in 1% of individuals, of which 0.1% required ICU care. So if we look at the data, if you compare the Delta admission numbers with the probable admission numbers for Omicron, you can see that 5% of Delta required, say, a sort of an ICU care or they were sick, whereas 1% of Omicron requires hospitalization and only 0.1% requires ICU care. But the problem here is that when we look at the transmissibility of Delta, when we compare the transmissibility of Delta with that of Omicron, the chance of the transmission dynamics of Omicron states that the chance of spreading to others is around 3 to 5% more in Omicron with that of Delta. And second is actually the reinfection risk or the risk of breakthrough infections. That is actually around 5 times higher than that of the Delta wave. Means that whatever and this immunity, the neutralizing antibodies that we have acquired as part of a natural infection or as part of vaccination or as part of this hybrid immunity. So that may not help us from getting infected with Omicron, but definitely because the T cells are intact, it might prevent progression to severe disease or ICU care. So we have to look at that these numbers in this regard. So Omicron, the severity is likely to be lesser because we have enough and more studies in the lab-based studies, in vitro studies, as well as in vivo studies, in vivo observational studies showing that when compared to the Delta virus, the Omicron replicates more rapidly in the bronchial tissue rather than in the lung tissue, means that the chance of Omicron spreading to others is actually higher compared to Delta, but the chance of the patient ending up with pneumonia is lesser because the replication in the lung is actually 10 times lesser in Omicron when compared with the replication in Delta virus infection. And other aspects like the syncytium formation in the lung, which actually accounts for the severity as far as Delta is concerned, has not been observed to the same extent in Omicron. So what these studies show is that the virulence per se, the Omicron is less virulent than Delta. The problem is going to be the stark number of patients who are going to get admitted at the same time. That applies to the healthcare workers as well, because the transmissibility is 5 times higher than that of, say, Delta, as well as the potential for reinfection, as well as breakthrough infection is also around 5 times higher for Delta. Okay. So what it conveys is that now, even if you are having a big problem with Omicron, the majority of the patients are going to be asymptomatic only. If you look at the Kerala data with regard to Omicron, so we had, say, more than 200 cases, around 75% of them were really asymptomatic. So we need to, most of them are international travelers, were very healthy, and the average age group was around, say, 20 to 40, etc. So that aspect also does play an important role. Out of these 200 patients, only one patient ended up in an ICU, and he also improved because he's a 84-year-old. So the thing is that, with Omicron, majority of infections are likely to be mildly symptomatic or to an extent asymptomatic, and the focus has to be on strengthening our home care services. So such cases usually recover with minimal interventions and accordingly may be managed at home under proper medical guidance and monitoring. So this is very, very important. So proper medical guidance and monitoring. It is not just giving them some drugs like azithromycin and making them believe that they will improve. It's nothing like that. The focus has to be on monitoring. And just showing this the chart to drive home one point, because we know what R0 means. Okay, the effective reproduction number. So R0 at the peak of the Delta wave, we know that what Delta wave did to India. So at the peak of Delta wave, the R0 in India was only 1.31. So the maximum R0 India has experienced till now was around, say, 1.83. That was in prior to the first lockdown, that is in 2020 April. So it was around 1.83. So during the peak of the Delta wave, also the R0 in India was only 1.36. But as of 4th Jan, it was 1.96. Yesterday, we heard from the Niti Aayog that the R0 in India has become around, say, 2.59. So it is the maximum R0 we have experienced during the outbreak in India as of now. The R0 of, say, 2.59. So it shows that the doubling time of Omicron is only, say, 1.5 to 2 days. So suppose we are having, say around, say, 10,000 cases of Omicron today, tomorrow it is going to be 20,000 cases. And that is how the health systems might get flooded because of sheer number of patients who get infected with Omicron. This is another look at the R0 of the different states. You can see that the pink one is the data as of December 27, 2020, and the yellow is the January 4. That is in 1 week, you can see that the R0 in Delhi, etc., has increased from 1.4 to 4.5. Yesterday, it was around 8. So in 1 week time, the R0 is increasing by, say, 8 to 10 times. This is a major problem. As of now in Kerala, you can see that R0 is still less than 1, means that, sort of under control, but it takes only a matter of a week for the things to change. That is what this graph shows, So in 1 week's time, the R0 in majority of the states have gone from below 1 to maybe around 4 to 5 to 6. So we need to look at these numbers very carefully, and it takes only a matter of, say, 1 week or so for the community transmission to set in, and then the numbers can really explode. So that is what you have seen from other states. But Kerala has some advantages because, our masking compared to other states is very good. Our compliance with the respiratory cuff etiquette, respiratory etiquette, and hand washing, the maintaining ventilation, following the 3 C's, all these things are compared to other states, pretty good. So what they means R0 to explode to around 8 to 10 times from baseline. It took only, say, 7 days in other states. In Kerala, it may take around 2 to 3 weeks, but still the numbers are likely to go up. So what actually decides the impact of this, the new variant of concern, Omicron? So one is the vulnerable population. So vulnerable population means that what actually prevents infection from occurring is the neutralizing antibody. And what prevents the severity, that is what prevents the admission in the ICU, death, etc., is going to be your intact T cell immunity. Okay, the memory T cells, etc. So from the studies till now, the lab-based studies as well as the observation studies, the real-life experiences, all those things put together, we know that the neutralizing antibodies following vaccination, as well as breakthrough infections or following natural infection alone, may not prevent infection from Omicron occurring. But then the T cells are, because 70% epitopes are preserved, so the T cells are still intact. So that can really prevent hospitalization on progression to severity. So this might not apply to a category of patients where, you know, the initial neutralizing antibody response itself would have been blunted, like the people above, say, 65 years of age, or those on immunosuppressants, and those with comorbidities like CKD, etc. So the vaccine-derived immunity as well as, you know, the natural infection-derived immunity as of now would have waned to a great extent. And in them, probably even Omicron can lead to the severe disease or hospitalization. So these sort of things we need to keep in mind while planning the home care advisory. The next aspect is actually the waning immunity. We know that following natural infection or following vaccination, after some time, the neutralizing antibody levels do go down. So we used to say that it's around 6 to 9 months. And probably that one of the reasons why, you know, the booster doses have been advised for the healthcare workers and those above 60 with comorbidity. So waning immunity is also a problem. So the first 2 points states that now almost all the state and all places in the world are, you know, the vulnerable as far as Omicron infection is concerned. Okay. Then variant of concern, we know that WHO, you know, labels a variant of interest as variant of concern if it satisfies either one of the 3 criteria: is increased transmissibility, increase in virulence, or the third one is there is increased risk of reinfection. Okay, so as far as Omicron is concerned, it was labeled as a variant of concern because of increased transmissibility compared with Delta, as well as because of increased risk of reinfection compared to the other variants of concern. Where variant behavior is not with regard to the virus, it is with regard to the populations. Variant behavior means, suppose your compliance with the masking is not very good. We know that. So as of now, the data shows that it's behaving more like an airborne infection. So it has been equated like measles as far as the spread is concerned. So the usual the mask, like the cloth mask, etc., is not going to prevent transmission. So you need to invest in very good quality masks like N95 mask is very, very important. So if the masking is not proper, if the physical distancing is not proper, etc., there is a chance for the virus to spread rapidly in the community. And the last aspect is the one which will really measure the impact. Now, when we look at other states and Kerala, we can see that during the peak of Delta wave, we never sort of allowed our healthcare system to get saturated. Okay, so compared to other states, you know, whether there was a dearth of ICU beds, etc., to an extent, I'm not saying that it was the case everywhere, but to an extent, so we were sort of able to blunt the peak to such an extent that majority of the patients who really required ICU care, we were able to offer the ICU care. With Omicron, the situation is going to be a bit more challenging because of the sheer number of cases that we should be expecting. For example, during the peak of Delta, the maximum number of cases in the state was to the tune of around 43,000 cases per day. So if you apply the mathematics, like say it is 3 to 5 times more transmissible than Delta, so then the everyday number of cases expected probably is going to be around, say, 1 lakh cases, out of which, so one person will require hospitalization, means it will be around say 1,000 hospitalizations per day and around 100 ICU admissions per day. So we need to keep all these metrics in mind. So this is just to show the rapidity with which in South Africa that we initially depend on the data from NICD South Africa, especially the data from the Gauteng province there. So here we can see that the green one is the Delta, and in 1 month's time, that's in 3 weeks' time, we can see that the pink one is actually Omicron. The entire Delta has been replaced by Omicron. So in South Africa, the prevalent strain at that point of time was the Delta strain, and the Delta was replaced by Omicron within a period of say just 3 weeks. And you can see in the beginning of December, again, the Delta is just a thin strip. So this slide is important as far as Kerala is concerned, because as of now, we believe that the majority of the isolates in Kerala belong to Delta. Okay, so for a period of time, from maybe weeks to 1 month, we might be having a co-circulation of Delta plus Omicron in the state. But then by that time, if you look at this chart, the Omicron will become the dominant population and will actually replace Delta altogether. Now, when we are talking about home care, so this is just a reminder of the phases of COVID-19. We know that there is a phase of early infection where the viral replication will go on. And then we are having the stage 2, that's the pulmonary phase, and the stage 3, that is the phase of hyperinflammation. Okay, so during the early phase, so our focus always should be, so when we are talking about home care, our focus always should be on identifying patients at the earliest who are likely to progress to the pulmonary phase. Okay, so that is in the pulmonary phase, the hallmark is going to be the hypoxia. This, if you are using the pulse oximetry, the saturation is less than, say, 94% and room air at rest, or if the respiratory rate is more than 24, that is actually a sort of a surrogate marker showing that hypoxia has occurred. But the Kerala has always focused on another aspect, because by the time the resting desaturation occurs, that means that the alveolar consolidation has begun. So we have actually wasted a therapeutic window of opportunity. That is, we know that the viral pneumonias or the bronchopneumonias, initially it will start as an interstitial pneumonia. Only the next step, there will be the exudation into the alveoli and alveolar consolidation will occur. So our ability depends on identifying the patients at the stage of this interstitial involvement itself. At the stage of interstitial involvement, the symptom is going to be the dry cough or increasing dry cough and exertional dyspnea. So we are asking the patient to be in home quarantine. We are not asking the patient to move about. So this exertional dyspnea may not be, perceivable to the patient if they are following the strict guidelines of taking rest. So in order to elicit this exertional desaturation, we use a test known as the 6-minute walk test. So 6-minute walk test, what we want the patient to do is not, like the usual 6-minute walk test. What we want is that any patient in home care, they should monitor their saturation at rest, maybe around say 3 times or 4 times, and they have to record it in a diary. And if they are able to walk, we don't want the patients with CKD or say cardiac failure to exert themselves, but those people who are stable enough to walk, they should walk inside the room for 6 minutes. Prior to that, they have to check their saturation, and they have to walk for 6 minutes slowly, and then they have to check the saturation again. So if there is a fall in saturation by 3%, that is, if the resting saturation was say around say 97%, and after walking for 6 minutes slowly, if the saturation has fallen by 3, that is now say it is less than 95, that means that so there is an exertional desaturation. Exertional desaturation means that so the interstitial involvement has started. So once the interstitial involvement starts, the patient will progress to the next stage, that is the alveolar consolidation will occur. So we know that from our experience over the last 2 years, the one drug which can actually make a lot of difference to the outcome of the patient is starting steroids at the right time. That's very, very important. Starting steroids at the right time. We don't want to start steroids for everyone because it will be detrimental to the patient. There's a viral clearance, etc. will be delayed. Also, the risk of superinfections with aspergillus as well as mucor, etc. can set in. But those patients with interstitial pneumonia, we need to identify at the earliest through the 6-minute walk test, and we need to start them on steroids at the earliest. This is actually very important. And when we look at the symptomatology in the early phase, so is there any difference between the symptoms of due to Delta and symptoms of Omicron? As of now, we are having the data from the European countries. Where we look through the data, the most important aspect is that only around 12% patients are having anosmia. We know that in Delta, we used to take the hallmark symptom as anosmia as well as dysgeusia. But in Omicron, the anosmia is present only in 12%. So this is actually one thing which might help in differentiating Delta from Omicron. It's not that anosmia is absent. Compared to Delta, only 12% of patients are having anosmia as well as dysphagia. The second aspect is that diarrhea. Diarrhea was present in maybe around say 40 to 50% with Delta. Whereas in the case series from Denmark, etc., diarrhea has been reported only in around 10%. So all of the classical symptoms like the fever, the sore throat, excessive headache, excessive fatigability, all these things apply to Omicron as well. The two differentiating features from the data sets from Europe says that anosmia, as well as South Africa says that anosmia is actually less prevalent in Omicron, as well as the diarrhea is less prevalent in Omicron. Now, when we go through our guidelines, everyone is familiar with the ABC and the categorization. So what A means, what B means, as well as what C means. In pregnancy, we again divide them into the B1 as well as B2. So B1 is A plus fever, and B2 is symptoms in those with comorbidities like age above 60 years and other comorbidities. So that is how we divide patients. And C, obviously, the patients with the red flag signs, that is dyspnea, chest pain, drowsiness, hypotension, hemoptysis, cyanosis, etc. So this thing we need to keep in mind. As for category A as well as category B, there is no hypoxia. But for category C, the patients have red flag signs and should definitely be hospitalized. And then majority of the criteria, the majority of the guidelines actually focus on mild, moderate, and severe. For therapeutic purposes, this is very, very important. So mild means that the respiratory rate is less than 24 and SpO2 is more than 94 on room air. The recent, actually the national guidelines actually have replaced this 94 with 93. So that does not make much of a difference. So we can stick on with 94. So respiratory rate less than 24 and SpO2 more than 94 is the mild cases. Ideally, the mild cases should be in home care. The moderate severity means that the respiratory rate is between 24 and 29, SpO2 is between 91 and 94. And severe is actually when the respiratory rate is more than 30 and SpO2 is less than 90. So the critical, the definition not important when we are talking about home care. Okay, so who are the patients, who are the ideal candidates to be put in home care? These are the patients who are asymptomatic or mild cases. The asymptomatic cases are lab confirmed cases, not experiencing any symptoms and having oxygen saturation at room air of more than 94%. So the clinically assigned mild cases are patients with upper respiratory tract symptoms without dyspnea and having oxygen saturation at room air of more than 94. So these are the patients who are the ideal candidates to be in home care. And the guidelines states that the patient should be clinically assigned as mild or asymptomatic case by the treating medical officer. So ideally, so since our eSanjeevani platform is very active, if the patient is not having that much of comorbidities, etc., the initial classification we can do using the eHealth platform. So eSanjeevani platform itself. Such cases ideally should have the requisite facility at the residence for self-isolation and for quarantining the family contacts. The experience with Omicron is that by the time one patient gets diagnosed with Omicron, the family spread would have occurred because the transmissibility is actually so high. Compared with Delta, the incubation period of Omicron as of now is around 3. For Alpha it was 5, for Delta it was 4, and for Omicron it is 3. And the secondary attack rate is actually so high. So if one person in the family is infected, we should take all measures to see that other family members are not getting infected, but it might not be possible in the case of Omicron. A caregiver should be available to provide 24/7 care for the patient, and this caregiver should not be having any comorbidities and should be ideally be a fully vaccinated individual. In Kerala, majority are fully vaccinated, so it should not be a problem. And there has to be a communication link between the caregiver and the hospital, and this is actually a prerequisite for the home isolation. So that the link could be with the Disha, it could be with the eSanjeevani platform, or it could be with the ASHA or the doctor in the PHC. Ideally, the elderly patients aged more than 60 years and those with other comorbidities. So if they opt for home care, they should be allowed to be in home isolation only after proper evaluation by the treating medical officer. We know that. So during Delta wave itself, one of the major issues increased home deaths and the patients reaching late to the hospitals with the ARDS, etc. So we need to avoid this from occurring during the Omicron wave. So we need to ensure that the proper message goes to the people in home care, and if the red flag signs are there, they should come to in the hospital at the right time. The patients suffering from immunocompromised status like HIV, transplant patients, cancer chemotherapy, they should never be allowed to be in home care. So this is actually from our own guidelines. That is a proposed 3-level monitoring mechanism for mild COVID-19 confirmed patients in home care. If you remember correctly, this guideline, which was released in 2020, talked only about asymptomatic patients. So the initial guidelines said that we will keep only the asymptomatic patients in home care, but now we need to keep the mildly symptomatic also in home care. It's very important. So this is actually the 3-level monitoring mechanism. One is the daily telephonic monitoring, which is actually performed by the eSanjeevani team or by the ASHA or the PHC. So we need to telephone the patients in home care and see whether they are developing any red flag signs. The second is actually the self-monitoring and reporting of symptoms. We cannot, when there is a huge surge of patients, we know that all these systems will collapse. So the most important thing is educating the public about the red flag signs, about the self-monitoring and the importance of reporting the red flag signs, etc. They should be made aware of. The third is actually the finger pulse oximetry record. Here also, we know that majority of the patients in home care never had access to any pulse oximeter. So we need to look at the surrogate methods like the single breath count, etc. So which can be taken as a poor surrogate, but still it's better than nothing. So we need to teach them about how to document this single breath count in the proper way. So this is actually a 3-level monitoring mechanism. This is an ideal scenario. So daily telephonic monitoring from the healthcare workers, self-monitoring and reporting of symptoms, as well as documenting the pulse oximetry. They need to look at the resting saturation, as well as they need to perform the 6-minute walk test. So this is actually the algorithm for asymptomatic, mildly symptomatic patients. So daily telephonic followed by the PHC MO or the designated person, that is usually the ASHA. They need to look for developing a persistence of fever or development of any red flag signs. If red flag signs are present, if the patient is developing red flag signs or if the patient is having persistent fever, say more than 5 days, etc. So ideally, they should be shifted to the COVID hospital. If they are not having any red flag signs, so we need to reassure them, we need to tell them about the importance of continuing monitoring, etc. They can be allowed to continue in home care. That is one aspect. That is a daily telephonic monitoring. The second aspect is the self-assessment of symptoms. Actually, in the Omicron scenario, etc., realistically speaking, after a point of time, probably the daily telephonic monitoring of all the patients may not be practical, may not be possible. During the surge of Delta wave also, I believe that to an extent, it was not possible to telephonically monitor everyone. That is, therein comes the importance of the second aspect. That is, teaching the patients the importance of the self-assessment of symptoms. Very, very important. So they need to observe for development of the persistence of fever or the red flag signs. And if they develop red flag signs, they need to contact the PSCMO, the Disha or the eSanjeevani, and definitely then they will get admitted. And second aspect is that if they are not developing any red flag signs, they can be allowed to be in home care. And the third aspect is the importance of daily pulse oximetry. And if the saturation is less than 94 in room air, or if they're doing the 6-minute walk test and there is exertional desaturation, and suppose they don't have access to pulse oximetry and they're using the single breath count. In such situation, the single breath count is less than 15 per second, then less than 15, then definitely they should contact the doctor, and ideally they should get admitted. And the red flag signs, so the presence of the breathlessness, the altered sensorium, drowsiness, hemoptysis, excessive fatigability, chest pain, palpitation, etc., or syncope, etc. These are the red flag signs, and if they are developing any red flag sign, definitely these patients should be hospitalized. Of which, when we go through this death data analysis and all, especially in elderly, the most important aspect is the presence of excessive fatigability. If someone in home care is complaining of excessive fatigability, it's very, very important. It is ideal to hospitalize them. So this is actually the checklist for self-reporting of the mild COVID-19 patients at home care. So this actually checklist Ideally, all the patients should be having this, the monitoring person should be having this checklist, and they should see whether the patient is having fever, is developing alteration of sensorium, patient is developing dyspnea, chest pain, drowsiness, hemoptysis, excessive fatigability, syncope, palpitation, and the pulse rate 90, so that's not very important. The SpO2 is less than 94% in room air, or if there is an exertional desaturation by 3, or if the single breath count is less than 15. So it's not second, is not there. If the single breath count is less than 15. So we have to monitor this thing. Ideally, when the ASHA is calling them, or if someone from eSanjeevani is calling them, ideally they should have a checklist like this, so that they won't miss any point. So fever per se is not an indication for admission, but if the fever is actually persisting for more than 3 days or 5 days, and then it becomes an indication for evaluating the patient. So ideally, the person who is actually telephonically monitoring those patients at home care should be using this checklist. This is from our guideline. And ideally, the persons at home, they should also be the caregiver of the patient should also be using the same checklist. They can also put on text. So this actually helps in actually sort of not missing any points, because if you are using a checklist, it is unlikely that you might miss any points while monitoring these patients in home care. So this is the same checklist can be used by the healthcare worker as well as by the caregiver at home. Now, another important aspect is the microcluster monitoring framework for home care of mildly symptomatic COVID-19 patients with vulnerable population at home. We know that almost all the households in Kerala have vulnerable population elderly at home. And in the context of Omicron, even with Delta, this was true that Delta was also associated with the cluster formation home. And Omicron, definitely there is a possibility that almost all the family members might get infected. So the most important thing is that the majority of the mildly symptomatic patients in room isolation may be having family members from vulnerable groups at home. So they are likely to be higher risk primary contacts by the time diagnosis is ascertained in the patient. So by the time we are putting the patient in room isolation, by that time itself, that person would have infected the vulnerable at home. So such homes with exposed vulnerable population should be considered as a micro cluster for monitoring. That means that even if the vulnerable population at home are not symptomatic now, they should also be thought to monitor themselves. That is actually the concept of self-monitoring. So the 3-level mechanism that we talked about, that is a telephonic monitoring as well as the self-monitoring as well as pulse oximetry, should be actually made applicable to them also. That is a vulnerable at home. So suppose there is an 80-year-old or a CKD patient at home, is a high risk contact. So we should not wait for them to develop symptoms and then ascertain the diagnosis and then start the monitoring process. By you have to start the monitoring process right from the beginning itself, so that we don't miss anything. Okay. So this is in short about the home monitoring, that is a daily telephonic monitoring, the self-monitoring of and reporting of symptoms, then finger pulse oximetry record and the single breath count, which is a surrogate for the finger pulse oximetry. The follow-up by the ASHA worker or JPHN or volunteer every 3rd day for assessment or development of symptoms in vulnerable exposed population at home. Or alternatively, the 3-level daily monitoring can be extended to vulnerable population at home also. So the thing is that, based on our logistics, initially all these things might be possible, but as the number of cases goes on increasing, then probably the 3-level monitoring mechanism, etc., might not work to the same extent as during the initial days. So that is the importance of the second aspect of the monitoring system. That is, we need to teach all the patients who are in home care about the red flag signs. That has to be the most important thing. As of now, the things which we observe is that the moment one patient is put in home care, they will be started on some drugs, and then the patients believe that these drugs will prevent the progression to severity. Instead of giving drugs should only be for symptomatic treatment, like giving paracetamol or cetirizine, like that. Only that they should be made aware of the importance of monitoring the red flag signs. That is the one thing which is going to make a huge difference, not the drugs that we are administering. So these are actually the guidelines for home isolation released by the Union Ministry on 5th January. So patient tested positive, then the doctor need to assess whether they are mild or asymptomatic patients. Then the criteria is that they should be mild or asymptomatic and they can be managed in home isolation. So the instructions for the patient are, so they can be, if they satisfy the criteria to be put in home care, they may be allowed to be in home care provided there is a well ventilated room and there is a dedicated caregiver at home who is actually fully vaccinated and don't have any comorbidities. Ideally, this patient should be put in a well ventilated room and he should be asked to wear a triple layer mask always. And then the caregiver, when the caregiver is entering the room of the patient, at that time, preferably, the caregiver should be putting on an N95 mask and the patient also should be putting on an N95 mask. The patient should be asked to maintain adequate hydration, follow the respiratory etiquettes, and follow hand hygiene. And the personal items should not be shared. All these things now we are well aware of. Then they need to monitor the pulse oximetry, saturation, all these things should be monitored. And the instructions for caregivers is that use triple layer mask. And the mask has to be replaced if wet or dirty with secretion. Even if they say triple layer mask, ideally they have an access to N95 mask. When taking care of the patient, they should be using the N95 mask. And while taking care of the patient, they should be using gloves and they should perform hand hygiene before and after using gloves, avoid direct contact with body fluids of patients, avoid exposure to contaminated items, and effective waste disposal also should be ensured. And now when coming to the treatment of patients with mild or asymptomatic disease, the most important aspect is the monitoring and not treatment. The treatment is actually limited to the paracetamol for fever, and if the fever is not coming down, naproxen, then antihistamines, and if the patient is having nasal block, etc., nasal drops, etc., nasal drops and all. That is actually about the treatment. Is just symptomatic treatment. It's not about administering antibiotics or any other antiviral drug while at home. The steroids are not indicated in mild disease and should not be self-administered. It's very, very important thing. The monitoring of the patient during home isolation, we have already discussed. And then the patient caregiver should seek the medical help if red flag signs are present, which we have already discussed. That is, unresolved high-grade fever, so more than 100 degree Fahrenheit for more than 3 days, and difficulty in breathing. All these things actually we have discussed. So this is actually data which came out of the mortality analysis, which was performed around 3 months back. You can see that during the peak of the Delta wave, we had many cases of death at home, death in transit, death on first day of hospital admission, then death on second day of hospital admission, death of third day of hospital admission. So what this means is that there is an admission delay. So any patient who is dying within, say, 3 days of hospital admission, or dying at home, dying in transit, etc., means that our home care monitoring system has failed because they are reaching very late to the hospital. So that is actually the importance of organizing this home care training session. So it is very good from the patient perspective to be in home care because the psychosocial support, etc., the alienation, etc., all these things are not there in home care, and they can also monitor themselves. But it is our responsibility to ensure that delayed presentation to the hospital does not happen. So if the monitoring, from our side, if the monitoring, because of logistical challenges, etc., if there is any problem in monitoring, when the number of cases goes up, by that time, we should be able to educate all about the importance of monitoring for red flag signs, the pulse oximetry monitoring, the importance of 6-minute walk test. If they don't have access to the pulse oximetry, the importance of doing the single breath count, all these things we should be able to educate. And actually, NHM is trying to give the electronic messages to the patients, means in home care, the family members, etc. Regarding the red flag signs to be monitored, how to do this single breath count, how to do this pulse oximetry, etc. So we have done this many times, but then probably in the public memory is pretty short, and probably we need to start that exercise again. So we need to ensure that anyone who is kept in home care knows the importance of monitoring for the red flag signs. the medications that we are giving should not give them any false sense of security. It is very, very important. That's the problem is that now many patients are being prescribed azithromycin, etc., despite knowing that no, azithromycin is not going to work. But the patients think that. So, we did an operational research on why the patients reach the hospital late. Now, the patients presenting with ARDS to the hospital. And the answer we got from majority were that, they have been asked to take some medications and they thought that medications will prevent them from progressing to severe dates. This is the problem. That might give them a false sense of security. So that should not happen. So the medication should be limited to symptomatic medication, and the time we are spending with the patient should be in educating them about what all things to be monitored while they are being kept in home care. It's very, very important, so that these numbers will look better when we are analyzing the data about Omicron. So we don't want any deaths at home, any death in transit, or deaths occurring within, say, 48 to 72 hours of hospitalization. And then we know that, so the home care, etc. So all these things, when while at the ground level, when the number of cases go up, may be very, very, very difficult. And that is the reason why, on 1st of May, the government came out with this circular, that is advisory on empowered home care. This was for internal circulation and triage for prioritization of hospital admission based on risk categorization. So we accepted that there might be delay in allocating resources, at least to some patients in some districts during the peak of Delta. Okay, so that is why this the guidelines got issued. Omicron also, even though the severity of Omicron is likely to be lesser, but since the number of patients who are likely to get infected is going to be huge, there is obviously a group of elderly as well as those with comorbidities who might actually require hospital care, not because it need not be directly due to the pneumonia due to Omicron, but it could be due to the decompensation underlying, say, a heart failure, or say worsening of CKD. All those things can happen even with a mild infection. So we should be prepared for that. And so I will take you through the empowered home care guidelines also. We know that those ideally the people should to be in home care are the asymptomatic or those with mild severity only. The people who are eligible for home isolation should be categorized clinically to mild or asymptomatic by the treating medical officer or by using the eSanjeevani or the telehealth platform, and they should be having a facility for isolation at home. And a caregiver who is ideally a vaccinated person without any comorbidity should be available to provide care throughout the day. And there should be a communication link between the caregiver and hospital. And this is a prerequisite for the entire duration of home isolation. Ideally, those with comorbidities should be allowed to be in home isolation only after consulting a doctor. Very, very important. And those who are immunocompromised, they should never be allowed to be in home isolation. Very, very important. But if there is a situation where we don't have any beds, they should be allowed to be in home isolation only after seeing a medical officer. Very, very important. And there should be a communication with a treating doctor, and promptly, in case of deterioration, it has to be reported. And what we mean by symptomatic treatment did not include the use of any antiviral drug. We know that now the antiviral drugs in home care is not going to be effective at all. What we mean by symptomatic treatment is taking care of fever, taking care of myalgia, taking care of sore throat, taking care of rhinitis. For all these things, no, we don't require any antibiotic. We just require anti-inflammatory drugs like paracetamol, and if the fever or the pain is not coming down, we can use naproxen. In one situation where, if the cough is increasing, so if it is not coming down by, say, 5 days or so, then there is limited evidence to show that the budesonide inhaler, that is when we are using in the dose of 800 BD for 5 to 7 days, can actually can have a local anti-inflammatory effect. Okay, and it might help with the cough and the progression to severe disease. So those patients who are having fever and cough for, say, more than 3 to 5 days, they can be put on budesonide. And then the importance of triaging for prioritization of hospitalization. As the pandemic progresses, we know that we experience delay in allocation of beds in COVID hospitals at the earliest for the needy. So in order to optimize the allocation of resources, patients in home care based on symptomatology should be categorized into red category as well as yellow category. So we know that just like the traffic signal, red category means that, so if suppose we are having only, say, two beds in a hospital, So those patients who fall in the red category should be allocated those 2 beds, whereas the yellow category can really wait. That's basically about the prioritization of for hospitalization, triaging for prioritization of hospitalization. So red category comprises of patients at increased risk of rapid deterioration, warranting immediate hospital admission. And the amber or the yellow category comprises of patients who are unwell or breathless, but not significantly so to merit immediate transfer to a secondary care setting. Such patients will be started on home-based oral steroids and anticoagulants if needed. Basically, we are buying time. This yellow category also eventually might require hospitalization, but as of now, probably we may not be having beds to be allocated to them. So whatever bed we have, we will allocate to the red category, and yellow category, meanwhile, will be treated at home. And once the bed becomes available, they will be shifted to the hospital. That is what is meant by this risk stratification. So who will categorize this thing into red and yellow? The mobile teams constituted by district authorities, you might be knowing, because now we had done all these things during the Delta wave, and all the district teams, the mobile teams were there. And using these mobile teams constituted by district authorities or by the nearby PHC or through the eSanjeevani or the telehealth platform with very good video interface, this stratification into red as well as amber category will be done. So based on our logistics, we can create workable models. So what do you mean by this red category? So those who meet one or more of the following criteria should immediately be shifted to the hospital. So the first aspect is with regard to the dyspnea, breathlessness. So if they have one or more of these, that is now when you are talking to them over the telephone, if they are so breathless that they are unable to speak a few words or complete a sentence, that means that they are having a resting desaturation and they should be considered as red category and should be immediately hospitalized. And suppose they say that the patient's breathing in the last hour has deteriorated significantly from the baseline. Okay, so there is a drastic deterioration, sudden deterioration. Such patients also fall into red category and should be hospitalized. And if the patient is saying that at rest itself, I am feeling dyspnea, that is resting desaturation. So these patients should not be having any underlying disease. Suppose a COPD patient, if you ask this question, they will say that, no, I am dyspneic at rest. That is not what we are meaning. It should be a new symptom. In such situation, the patient should be considered as falling into the red category and should be hospitalized. Sudden onset of dyspnea. Maybe for the first 7 days, the patient will be having mild symptoms, and on 8th day, the patient is saying that I am having sudden onset of dyspnea. Such patients also should be hospitalized. Okay. And suppose the patient is having access to pulse oximeter, and the resting saturation is less than 94. That is also an indication for hospitalization. The problem here is that pulse oximeter may not be available to many households. In such situation, we should resort to the single breath holding test. That is, the patient has to take a full but not too deep breath and hold it as long as possible. That is, take a deep breath and ask them to see for how long they can hold the breath. That is the single breath holding test. So ideally, if they are able to hold their breath for more than 25 seconds, that means that they're having a very good or normal cardiopulmonary reserve. If it is between 15 to 25 seconds, means that sort of a compromise or a borderline cardiopulmonary reserve. Less than 15 seconds means that they have a severe compromise of the cardiopulmonary reserve. So it's not up to mark. So less than 15 seconds means they fall into the red category. That is a single breath holding test. That is, they have asked them to teach them to take a deep breath, take a full breath, not a very deep breath, take a full breath and see for how long they are able to hold their breath. So this can be taken as a poor man's surrogate marker for pulse oximetry. And those who have access to pulse oximeter, we should teach them about the 6-minute walk test. Ask them to walk for 6 minutes slowly at their own pace in their room and see whether now after walking for 6 minutes, there is a drop in saturation by around 3%. This is very important. So if there is a drop in saturation by 3, it means that there is interstitial involvement. So when demand is more, the lung is not able to supply enough oxygen to meet the demands of the body. So that is also important. That means that, so the patients might improve with steroids. So this is with regard to the criteria under dyspnea in red category. Second aspect is, suppose the patient is having shock or a peripheral shutdown. How can we identify this over the telemedicine platform? It's important. Suppose the patient bystander is saying that the patient is having confusion or reduced level of consciousness. That means that, so don't think about encephalitis per se. One of the reasons for this the confusion could be a decrease in the cerebral perfusion. So such patients will fall into red category and requires immediate hospitalization. Suppose the caregiver says that, or even the patient is saying that my extremities are cold and clammy. That also means that there is some problem with the peripheral circulation and the patient requires immediate hospitalization. And then if the bystander is saying that, no, the patient is looking very pale, the pallor, or the patient, the extremities are blue, or if the urine output is actually very less in the last 24 hours, these all can be taken as surrogate symptoms which might suggest shock. And these patients should be considered as being in the red category and should be hospitalized at the earliest. It's very important. And then the third aspect is functional impairment. Suppose there is no bystander, the patient cannot care for himself, they are unable to perform activities of daily living. Such patients, it will be, it's not prudent to keep them under home care and they should be hospitalized. In history of a recent hospital admission with COVID or a confirmed diagnosis of COVID-19 means that no patient has been diagnosed as COVID-19, was discharged from hospital, say 10 days later, and now the patient is complaining of dyspnea and all. We know that there is actually the progression into the hyperinflammatory stage and the patient should be hospitalized at the earliest. And then suppose the patient is having other problems like CKD and all those things, the patients will fall into the right criteria and they should be hospitalized at the earliest. So if the patient satisfies any of these aspects and fall into the red category, they should be, whatever hospital bed is there, so at the earliest has to be allotted to the patients in red category. Now, when we look at the yellow category, these patients are also sick, but then we can buy time by timely initiation of some drugs while they are in home care itself. So if patients in home care meet one or more of the following criteria, they should be reviewed in a primary care setting by mobile teams or over the eSanjeevani platform. So what comprises these symptoms under yellow category are, one is the breathing has worsened in the last 24 hours. There is no, you are conducting a telephonic interview, the patient is able to speak to you. There is no the difficulty in speaking. That means that the patient is not in the red category. Patient is saying that over the last 24 hours, I have become dyspneic. So if the patient says I have become dyspneic over the last 1 hour, put the patient in the red category. If they say that no, there has been a slow worsening over the last 24 hours, they will fall into the yellow category. The patient is saying that no, breathing has never been this bad before. This actually applies to COPD patients and all. So they are dyspneic. The dyspnea is a part of their life. But if they say that no, I have never been this bad, then take it as yellow category. Then exertional desaturation, breathlessness on exertion. So this has to be a new symptom. So we in the red category, it is dyspnea at rest. If it is dyspnea on exertion, that is, if there is exertion desaturation, take it as a yellow category symptom. Suppose the patient is on inhalers for COPD and the patient is now saying that, I have been using the usual dose of MDA prescribed to me, but still I am not feeling better, then take it as an yellow category symptom. And if the SpO2 is more than 94 at room air at rest, with desaturation of 3% from baseline after walking for 6 minutes, that is exertional desaturation, take it as an yellow category symptom. Single breath holding more than 15 seconds. Okay, that's important. The patient, if it is more than 25, if the patient is able to hold more than 25, it is actually normal cardiopulmonary reserve. Less than 15 means it's a highly compromised cardiopulmonary reserve. 15 to 25 seconds means that, the cardiopulmonary reserve is actually sort of compromised. So such patients, their single breath holding time is between 15 to 25 seconds, they fall into this yellow category. If patients belonging to high risk category meet one or more of the criteria in the yellow category, they should be prioritized for hospitalization. That is, we need to start them on some drugs, and when the next hospital bed is available, we need to hospitalize them also. So this is basically the algorithm. So red category, anyone who is falling into red category, immediate hospitalization. So whatever ICU beds or whatever hospital beds we are having, we should earmark them to the red category patients. Yellow category, patients having symptoms, which make them fall into the yellow category, you need to see whether the patient belong to any high risk group. High risk group means CKD, age above 60, like that. If they fall into this high risk group, then also consider immediate hospitalization. If they don't fall into this high risk group, then probably we might be able to buy time by starting oral steroids. That is for those patients who fall into this yellow category. This does not say that we need to start oral steroids for everyone. We need to start oral steroids only for those patients who are in yellow category, for whom we may not be able to allocate a hospital bed immediately. For such patients, in order to buy time, we can start oral steroids, that is dexamethasone 8 milligram per day or methylprednisolone 32 milligram per day or prednisolone 40 milligram per day, and we can continue for 7 to 10 days. So when we are starting oral steroids, we need to ensure that the patient is not a diabetic. If the patient is a diabetic and don't have access to glucometer, etc., then it may be a very, very disastrous decision. Excuse me. And if the patient is dyspneic, then it becomes a criteria for starting anticoagulant. Also, any patient who is hypoxemic actually might benefit from anticoagulation. Such patients can be started on rivaroxaban 10 milligram per day. If it is not available, aspirin, recent recovery trial and all those things have shown that aspirin cannot be considered as an anticoagulant, it is an antiplatelet drug. But if the patient can't afford rivaroxaban, then probably as a poor man's alternative, you can start the patient on aspirin, even though it's not been provided to have any benefit. Before starting anticoagulation, we need to assess for the contraindication for anticoagulation, like active bleeding, malignant hypertension, then bleeding diathesis like hemophilia, recent surgery, or a platelet count less than 25,000. Okay, so those patients who are falling to red category, they are immediately shifted to the hospital. Those patients who are falling to yellow category, then again there is a if they are having higher risk factors, they should be put into the red category. If they are not having any higher risk factors, they will be started on oral steroids at home and oral anticoagulants at home, and then their clinical situation will be reassessed every 12 hours, and then if there is any progression to red category, they should be hospitalized. In case of delay in transporting red category patients to hospital, ideally the home oxygen through cylinders may be started at the rate of 10 to 15 liters per minute under medical supervision only. Now, the most important aspect is, COVID-19 stewardship, that is starting the right drug at the right time, the right duration, right dose for the right patient. Because, our focus is that, our patients also love medicine. So the thing is that it's also easier for us to prescribe medicine than give the right directives. That's very, very important. We should understand that we have enough experience in treating COVID-19. All of us do have enough experience in treating COVID-19. We know that majority of the drugs that we use, like say azithromycin or doxycycline, the vitamin C, the vitamin D, all these things do not have any benefit. Multiple trials have shown that does not prevent progression to severe disease. But then the other argument is that will they do any harm? So will giving vitamin C or vitamin D to the patient do any harm? Azithromycin will do harm because it can drive up the antimicrobial resistance. But what about vitamin C? What about vitamin D? Will it do any harm? The problem here is that it might give a false sense of security to the patient. The patient will think that this vitamin C and vitamin D might prevent the progression to severe disease. That is the issue. There is no harm in giving these vitamins. But the thing is that we should not actually forget to tell them that the most important thing that you should be doing is you should be maintaining a diary. You should be looking at your single breath count or pulse oximetry, 6-minute walk test. You should be looking for the red flag signs for at least for the next 10 days and inform about the red flag signs. That should be the most important thing that we should be teaching them. And we all know that the treatment guidelines, the state treatment guidelines have talked about using monoclonal antibodies even for patients with mild symptoms, because the monoclonal antibodies is an intervention, that is casirivimab and imdivimab should be given as early as possible. That is, even patients in home care, if they satisfy this criteria, it is body mass index is more than 35, the CKD with EGFR less than 16, diabetes mellitus with HbA1c more than 10, or diabetes with end organ damage, CLD, immunocompromising conditions, currently receiving immunosuppressive treatment, age above 65, cardiovascular disease, chronic respiratory disease, malignancies with chance of survival, etc. So These sort of patients should ideally not be in home care. They should be in CFLTC or CSLTCs only. And one intervention which we used to use during Delta was giving the monoclonal antibody. But then, if Omicron becomes the dominant strain in Kerala, then we know that there is a significant loss of neutralization by most of the monoclonal antibodies for this Omicron. Means that the Casirivimab, Imdevimab is not going to work against Omicron at all. So one of our very strong weapon when used early for patients with high risk factors, which might have prevented the progression to severity, is useless in case of Omicron infection. The only monoclonal antibody which actually retains its neutralizing efficacy is Sotrovimab, which is as of now not available in India. So as Omicron is concerned, so even for higher risk individuals, what remains is monitoring, meticulous monitoring at home. That's the most important thing. So the take-home message has to be, we need to focus on meticulous monitoring, timely identification of red flag signs, SpO2 monitoring, 6-minute walk test, and single breath count. So our focus has to be on this. There is no harm in using vitamin C or vitamin D. The problem is our focus always has to be on teaching the people in home care as well as the caregivers as well as others, because what we are going to expect in case of an Omicron surge is going to be the family clusters. So all of them should be made aware of the red flag signs, should be made aware of the importance of keeping a diary, should be made aware of the importance of monitoring their saturation stress, should be made aware of the importance of doing 6-minute walk test. And if they don't have an access to pulse oximeter, single breath count should be taught to them. This is actually much more important than the medications that we give. Thank you very much. Thank you.